Good morning, everyone. Today, August 19th, we are back here again from Mount Sinai Medical Center in New York City to come up with our monthly live peripheral interventional cases. Before we go up to Dr. Krishnan to start with the case, I'll just try to give you a couple of updates. We actually have a free App Store app. You just have to log in and go into CCVVC, and you can download the app and watch all the videos without internet connection. For any questions regarding this live case, please email us at info@peripheral-interventions.org. The video of this broadcast will be put up on the website by next week. We already have the video from last month online ready to go. And the next live case is scheduled on September 23rd. So I'll let Dr. Krishnan take over and go ahead with the case. Morning, Dr. Krishnan.
Good morning, everyone, and thank you so much for joining us today. We have actually a very interesting live case. We had a little bit of a late start. Our patient was a little late, so forgive me as I start and do all this prep work. So we're going to present the case. My fellow Dr. Jain should be coming over there to present it to you from over there, from the studio over there. But it's another example of a below knee intervention, which I think is very important for our audience to see and understand. Is Dr. Jain ready?
Yes.
Okay, Sachin, why don't you present the case?
Yes, sure. So we have a very interesting case today. Our patient is an 88-year-old woman presenting with left lower extremity big toe ulcer. It's on the dorsal aspect. If you go with the angiosome, it's a AT region. Patient also has a claudication at rest. So she is Rutherford Class III with category 5. Medical history is significant for hypertension, hyperlipidemia, paroxysmal atrial flutter, in and out of that. Patient is ex-smoker, and patient has a chronic kidney disease, creatinine ranging between 1.8 to 2.1. Our medications include Aspirin, Pletal, recently started on Plavix, Metoprolol for rate control, Rosuvastatin and Furosemide. As outpatient, patient underwent ultrasound Duplex that showed severe stenosis of the left SFA distally and also infrapopliteal vessel occlusions. So on August 10, 2015, patient underwent left SFA distal directional athrectomy and drug-coated balloon angioplasty. We did not proceed further because of the high creatinine. We want to minimize the contrast. And today the patient is here for Antegrade retrograde approach, percutaneous transluminal angioplasty of the left AT, the angiosome for the big toe ulcer, which is on the dorsal aspect. Back to PK.
Oh, great. Come on over, Sachin. So, Vishal, this is a really interesting patient. So, I'm going to take pictures because obviously with the contrast, I want to minimize the amount of pictures that we do. So this is a lady, who's actually been offered amputation twice. Initially had a lot of rest pain as he went through because of multivessel disease. And I think for our audience, what's important to remember is that most of these elderly patients present with multivessel disease and therefore have this kind of rest pain syndrome. It's very important to what is it called, stage these procedures in a manner that's actually very good for the patient. So what we tend to do, and I think the right thing to do, especially even though it is CLI, as long as it's not anything fulminating gas gangrene, which would lead to amputation anyway, or anything really pressing, I think what we tend to do is go ahead and stage these patients. So like Dr. Sachin said, she came in with a creatinine of 2.1. The first time we hydrated her, we kept her in-house, and then we went ahead and we did intervention of the SFA. So at that time, we took multiple shots of not only the SFA but below knee. We also did a good runoff and also had a good inflow picture. So our inflow showed that she basically, her iliac anatomy was very favorable for going up and over. So we just gave it like a 2 cc today just to repeat it for us to assist us in getting up and over. And once we're up and over, we're not going to take any. Can you please rail me? Can you rail me, please? Don't allow that wire to go forward. We're not going to go ahead and take any more pictures at this stage. What I'm going to do is go all the way down there first, and I want to show you the anatomy from below. So you can see here that what I've chosen to do is to go with a fine cross catheter, which is, it could be any export transport type catheter, which is going to give us support. So the logic here is that you want to get it to the point where you can have support of the wire and allow for a little bit of pushability of the wire without the wire pushing you back. So now I'm going to go ahead and take a couple of pictures for you guys to see what's happening. And I'm going to use digital subtraction imaging, and I want to take good pictures so this way I don't have to repeat them. So important for the audience to remember, when you do below-knee intervention, it's really important for you to understand the anatomy and the cap, both the proximal and the distal cap. Now, I know that a lot of people out there are doing retrograde, tibial sticks, and all this. In our experience and in our hands, I would say about 90% of lesions can be crossed in the regular antegrade way, rather than go retrograde to the pedal. So we tend to be very aggressive, going up and over, which also is really not a normal approach. A lot of people go antegrade, but we've had quite a good success doing this. Obviously, that needs to be part of your armamentarium if you are going to do it, and you have to be prepared at a moment's notice to get pedal access if you fail. So it's never our first approach, and I really want to implore our audience to see that do not just go directly for the pedal. Give an antegrade approach with a proper wire selection and a proper attempt before you go ahead and jeopardize the pedal access. I believe, in my opinion, pedal access is being overused, but I still think at the same time it's a very, very important part of our skill set in order to take care of these patients. Now, having said that, what are the parameters that we need to look at angiographically before we start? Well, first and foremost, you need to understand the takeoff of the anterior tibial artery. Second, you need to understand the occlusion of the anterior tibial artery proximally. So what do we look for? We look for calcification. We look for collateralization. So we have multiple collaterals coming off at the time of occlusion, or at the point of occlusion. Then we know it's going to be a little bit more difficult. 3 is we look at the distal reconstitution zone, and we look for what's called as hibernation. So what happens is when you take a picture of the distal dorsalis pedis, you'll see a vessel that fills, but fills albeit a little bit slower. So therefore, you know that that area is going to be hibernating, and the occlusion may not be as long as you think it is. So I think a lot of times people say, oh my God, it's such a long occlusion, and in reality it's not. You have a short segment occlusion with a long hibernating segment, and then into the foot. Now, having said that, I'm going to go ahead and demonstrate hopefully the things that I want to show you. So I'm just going to go ahead. Our anticoagulation strategy here is to give a bivalrudin. So we're going with bivalrudin, and obviously I've got my catheter. I'm going to pull my catheter back a little bit about there. So now I'm going to inject. So we've got diluted contrast, so we'll see how it looks. So there it goes. So there it is. See, right now, you can see the takeoff of the AT. There's the perineal that's occluded. You see the AT occludes right there. And then you can see as you come down, you start to see islands of anterior tibial artery. You see, it stops there, and then you have no island there in the middle. So anywhere from 20 to 25, I don't know if you could see it there.
Right.
You can see it's completely occluded. And now what I'm going to do is I'm going to come further down. And then I'm going to show you what I mean by hibernation. So you can see the anterior tibial artery again is going to come. You can see how bad the flow is here. There's the posterior tibial artery. That, again, collateralizing. And there's the anterior tibial artery coming all the way down near the foot. Now I'm going to go into the foot again. This time I'm going to inject and wait. And there's the anterior tibial artery in the foot. And that's the other segment that's hibernating. You see that?
Yes.
So that's a hibernating segment. So you see that this lady has a lot of reasons to have critical limb ischemia, but it's very important to go ahead and try this. So what we're going to do now is we're going to go up top, and I suggest to everybody, please start with a hydrophilic wire, because I think it's steerable. It allows you to figure out where you need to go. Forgive me as my pedal got stuck. So it allows you to easily steer into that anterior tibial artery. So this is going to be our plan right now. Our wire selection is going to be going with the fielder. Once we get the fielder into the anterior tibial artery, what we're going to do is we're going to go with a fine cross support. And then once we get the fine cross support in, then we're going to go ahead and decide what to do in terms of whether we upgrade or not. Vishal, any thoughts on your experience with crossing devices? Did you do anything differently? What are your thoughts?
No, I mean, specifically in this case, like you said, it's the utmost important feature is defining the AT or the lesion itself, the extent, the length, and then of course, like you said, the hibernating. So till the time you don't have good anatomical marks, your success rate can be different. So in this case, you perfectly demonstrated how the AT reconstitutes distally and comes back up. So it might be a little bit shorter lesion than what it looks. So after defining your anatomy, then I usually try to do the same way. Fine cross with an 014 wire, a hydrophilic with a little bit of support, might use a confines, a little bit more aggressive, and then take it from there. My personal experience with crossing devices below the knee, I'm not a big fan, but I keep it to the simple wire catheter techniques. But
well, you know, the crossing devices below the knee, you have the crosser, you have the Viance that people can try to use. And you know, I want to show the technique of us trying to cross this first. And then I'm going to have, Sachin, are you still there? Yeah. Because I think what you should do is present the data on the different things after we cross. So you can see here, what we're doing now is you saw how the wire got into that collateral, right? And I want to implore to everybody, it's very important that you need to know the generalized route of the AT. And you know the anterior tibial artery, how it's going to run. You want to use angiographic clues such as calcification in order to be able to direct the wire in the manner that you want to direct it. So now obviously this is a much more powerful wire. This is the Confianza. You see that? That little deflection is a little worrisome. See that? That's very worrisome.
Right.
So you know that that's not the way the AT is going to go. That's also another issue there. So the issue becomes is where is the true AT, right? So sometimes at this stage, you might want to actually give dye through this catheter because you know you're in a hibernating segment here. So for demonstration purposes, what I'm going to do is I'm going to go ahead and give a little bit of dye, okay, into the AT at this level. Can I have a 5 cc syringe? Always try to use smaller syringes when you give this kind of dye so you can really see. And before we create any issues, you just want to go ahead and give like maybe 2 cc's of dye. Okay, that's it. Okay, and see where we are. So I think this is a very important teaching tool. You know, obviously, you know, I could just do it the way I normally do it. But again, I think it's important for me to show you where you are and then decide how to do this. So you can see as we inject, you can see right there. So you have an occluded segment and then you have a collateral coming off. So now you know which way you have to go, right? So now, even though, I mean, having done a lot of these, I kind of know which way I need to go. I'm going to show you the use of these more stiffer wires to get this purpose done. And when you have an anatomic visualization, you can be confidently pushing rather than sort of guessing where you're pushing. So now I know I didn't give a lot of dye. Again, I told you the creatinine a little high, as Dr. Jane told you. So what we're going to use is we're going to go with the fine cross, and now we're just going to go ahead. See, that's the occluded that's the hibernating segment, right? Now there's my curve there, and that's not where I want to go. We know that, right? And again, this is part of the reason why sometimes it's very difficult to take it to this level. Now, I don't know if I'm in the right spot here, but I know that up to here I'm in the right spot. So I'm going to take it up to here. And then what I'm going to do is I'm going to go ahead, come off road map, and then I'm going to kind of get a sense of how this wire behaves. The behavior of the wire is also very, very important. See, that's not where we want to go. We know that. That's definitely not it. So we're going to come back here and try to redirect. So while I'm working on this, I'm going to ask Dr. Jane to start with his presentation on the ability of or the viability of different interventional techniques in below the knee. Sachin?
Yeah, I'm ready. So I made a short presentation on what are the therapy we have for infrapopliteal lesions.
Sachin, if you can stop there,
okay,
and come back here for a second. You see how the wire is pointing now? Now I've got it directed away from that collateral. Okay, so guys, while he's presenting, can you put this up side by side so the audience can see us work as well? I'm sorry, go ahead.
Okay. So what are the therapies available for infrapopliteal lesions? So first indications, just sum it up, for patients with combined inflow and outflow disease with the CLI, inflow lesion should be addressed first. That's what we did in this case. We addressed the SFA, we bringing the patient again, and then once we fix the inflow, then we can bring and or at the same setting we can do the outflow revascularization. And if the patient is going for any foot surgery and there is a concern of significant PAD, then preoperative angio can be performed. So SKY just released appropriateness criteria a couple of years ago. So this slide is very busy, but put it together, patients are divided into two categories, claudicants and CLI. So claudicants include Rutherford category 2 and 3, and in this, if the patient has 2 or 3 vessel infrapopliteal lesions, and if the arterial target lesion is focal, then it's appropriate to go and revascularize that infrapopliteal lesion. And otherwise, if the patient has a ischemic rest pain, if the patient has a minor tissue loss or major tissue loss, then it's appropriate to go and take care of the infrapopliteal lesion as we are doing in this case. Why tibiopedal vessels are different? As we know, these are small diameter vessels. There is always a long and multiple lesions, always chronic total occlusions. Very rarely we see any severe stenosis. And as far as calcification, we know that up to 70 to 80% of the lesions have a severe calcification covering more than 180 degrees in the arc. That there is higher rates of failure for revascularization, and even when we do revascularization, there is a higher rate of restenosis with any available therapy what we have. The goal is to maintain patency for wound healing, for limb salvage, but as we know, there is a very diverse dichotomy exists between the patency rates, restenosis, target lesion revascularization and limb salvage rates, and very few patients we have, we do it for claudicants. But I want to go over the endpoints because that's very important, because when we look at the endpoints for all these, the primary patency is freedom from balloon angioplasty until the repeat intervention to maintain lumen. Binary restenosis includes more than 50% stenosis of the target lesion. Target lesion revascularization includes any repeat intervention of the target lesion, and the limb salvage or amputation free survival is without need for any major amputation, what we call at or above the level of ankle. So in infrapopliteal lesions, overall the primary patency rate with any therapy is less, but the limb salvage is very good as long as we do the angioplasty of the infrapopliteal lesions, and very little number of patients will need a target vessel revascularization where they need another intervention. So keeping in that mind, what are the options we have in infrapopliteal lesions? Just standard plain old angioplasty, or specialty balloon angioplasty with maybe angiosculp or cutting balloon or chocolate balloon, bare metal or drug eluting stents, a role for cryoplasty is there. Athrectomy, we know there is a directional, orbital, laser, Jetstream, rotational and Phoenix. Drug coated balloon angioplasty will just have, I have a slide on that. Athrectomy followed by DCBs and other modalities like focal steroid injection in the infrapopliteal lesions. So what do we have data on just a plain old angioplasty? As we know from multiple studies, this is a safe, cost effective. It works both on short and long lesions. It has a higher failure rate, so we need an additional tool to open the lesions. Bailout stenting is between 15 to 30%. Primary rate patency is only 50%, but if you look at the limb salvage, it's up to 90 to 95%. And target vessel revascularization, there is another attempt to go and open the blockage is up to 40%. This is from multiple studies, so I didn't have any quote here. What about specialty balloon? I have slide for each, so we'll just put things together. For angiosculpt, they studied in 36 lesions. We don't know the length or occlusion, but they quoted 100% technical success with a 35% bailout stenting. So there is a lot of dissections that needed stenting. Primary patency is up to 60% at 1 year, and limb salvage rates are very good, up to 90% at 1 year. Chocolate balloon from the chocolate bar registry. The concept of having a scoring balloon with this is it reduces dissections, because in angioplasty there is a lot of dissection and there is a need for bailout stenting. So in this they studied up to lesions up to 90 to 100 millimeters, good procedural success rate. Bailout stenting was needed only in 6%. Usually with a regular balloon angioplasty there is up to 15 to 20%, and good salvage rate, limb salvage rate up to 97%. Cryoplasty has been studied with the chill BTK trial up to 115 lesions. These are short lesion lengths. If you see they are like 40 millimeter lesions with 40% occlusion, good technical success. In that study the primary patency was up to 80% and limb salvage rate at 85%. Let's talk about the stents in infrapopliteal lesions. This is a very busy study. I have put 5 studies together, studied between drug-eluting stent versus PTA, drug-eluting stent versus BMS. If you look at the lesion length, they are all short lesions. The maximum is up to 31 millimeter. But putting everything together, it seems like drug-eluting stent has a better patency rate, better stenosis compared to PTA versus bare metal stents, and overall with use any therapy the limb salvage rates are very good. They have studied both everolimus and sirolimus. So the take home message from this slide is, if you have to use a stent, it has to be a drug eluting stent. What about athrectomy? So orbital athrectomy was studied in calcium 360. There are 25 lesions in each arm, orbital athrectomy versus PTA. Good technical success. There is a need for 7% bailout stenting in orbital athrectomy. Good patency rate. They quoted up to 90%. Limb salvage rate is very good, 100%. What about directional or excisional athrectomy? This is from the definitive study, studied with 189 lesions. Lesion lengths are significantly longer here, up to 80 to 130 millimeters. 20% total occlusion, good success rate. Bailout stenting was needed in 1 to 5% of the patients. Patency is also good, around 80 to 90%, and limb salvage rates are very good at 95%. Laser athrectomy, it's another athrectomy device studied in a lazy multi-center trial, 155 lesions. Here you see the lesion lengths are longer, 160 millimeters. 90% are total occluded lesions, really real the life procedures. Good technical success, but bailout stenting was needed up to 45%. And if you look at the limb salvage rates, it's 93% at 6 months, and few people up to 15% needed a revascularization at 6 months. Jetstream atherectomy, this is a aspiration and rotational atherectomy device. This is from the multi-center pathway PVD trial. Out of the trial, which included 210 lesions, 18 were infrapopliteal lesions. So we cannot derive a whole from the study, but what we can see is again the short length lesions, good success rate. Bailout stenting was needed in 7%, but this is overall for all the lesions. Primary patency for infrapop is up to 60%, and the limb salvage rate is again good at 99% at 6 months. So this is very important because we are using a lot of drug coated balloons in the fempop. What about the infrapop? So the study that is published is Impact Deep, multi-center prospective trial, DCB versus PTA plain angioplasty. 358 lesions were enrolled in 2-to-1 fashion. Relatively longer lesion up to 10 centimeters, close to 40% occlusions, good success rate technically. Still there is a binary restenosis, 40% versus 36%. Target vessel revascularization was needed in 12% of the lesions. But if you look at the major amputation rate, there is a significantly higher trend in DCB arm. The thought process is that significant amount of distal embolization of the paclitaxel drug versus it just occurrence because of the nature of the study. So overall DCB at this point is still in test. Couple of other trials are going on. Lutonix is doing with the BTK trial. ADCAT trial is ongoing, which is including athrectomy and DCB. So at the end, what do we have as a therapeutic options and what are the patency rates? For standard balloon angioplasty is close to 50%, specialty balloon angioplasty is close to 60%, bare metal stents 60%, drug-eluting stents is better with 80 to 90%, athrectomy is close to 60 to 80%. Drug-coated balloon at this time is patency 60% but trend towards higher amputation rates, and athrectomy followed by DCB we still don't have any data. But as I told you at the conclusion, PTA is safe, cost effective with high limb salvage rates. Drug-eluting stents show superiority in patency rate in short lesions. Drug-coated balloon still in test. Athrectomy devices are great adjunctive tools, but we don't have much outcome data. So at the end I want to say that there is still a dichotomy exists between the patency rate, restenosis, target lesion revascularization and limb salvage rates. The patency rate are poor with any therapeutic options we have, but the limb salvage rates are very high. So this is where we stand at this point for infrapopliteal lesions. Thank you very much. PK, back to you.
Okay, so you can see here we're trying to get into the tibial vessel here, into the pedal vessel, because we were unable to get regular access from above, which again, like I said, you have to be prepared to go one or the other. So we are going to now try to do our usual pedal stick. So you can see here that right now I'm adjusting this to see where we need to enter. So what you have to do is in multiple views see it. So what we're going to do is we're going to go to another view. And I'm going to take another look here. And just got to adjust the needle to the spot that you need to be at. You can see I'm very close in two views.
Yeah, almost
So
on top
now
of
what
it.
I'm going to do is I'm just going to adjust a little bit over to right about there. And Sunil is going to tell me when I get blood back. Sometimes you might have to switch to another needle, or another type of needle rather than this needle. And which is what I'm going to have to do, looks like. Maybe go to a radial type needle here. This is not it. Not it. I'm probably sliding right on top of it. So I'm going to go ahead and switch to another needle. Give me the radial needle, guys. So we tend to use more radial needles in these kind of accesses, in these little old ladies.
So Dr. Krishnan, so your preferred mode is fluoroscopy. I mean, how much do you take ultrasound help in doing pedal accesses? If primarily you go pedal, do you go ultrasound?
I think if you go primarily pedal, you have to be very good at ultrasound. There's no question about that. We tend to do more fluoroscopy-based pedal access, but you know sometimes sometimes you're going to have to convert it to ultrasound, which we may have to do in this case here. So let me just try a couple of more times in the area that I think it is. And generally speaking, I know I'm very close.
Right.
So I'm just going to go very, very gently with my needle and try to just enter it in there. And it's really inch-wise going in. Any thoughts on what's your technique of doing this usually?
I mean, I do essentially, I mean, I usually like to keep the ultrasound on the side, but because you already have good fluoroscopic access and we can do a roadmap like you're doing, I think it works great. And then specifically getting two views, because we have to understand it's a two-dimensional system which we're accessing into a three-dimension. So getting an LAO, RAO, contralateral, like it seems you're right on top of it, but maybe on the side. So
that's what it looks like right here.
Right, exactly. So we just have to take different views to really establish our access point in the
Right, I'm going to try on this view here. Because up top, as you saw when Sachin was talking, it kept going into the wrong vessel.
Right.
And I think that I was getting really subintimal to the point where I was not happy as to how it's turning out. So there you go, right there. It's a very robust one up above. Maybe we should go up above rather than below.
Yeah, maybe a higher stick might help you.
Yeah, maybe better here rather than a lower stick like right there.
You're right there.
Nope, I think I have to go up above. I think it may be better for me to stick a little higher rather than at the level of the foot. Lo siento. Problem is sometimes the patients are moving.
Right.
Let me see. Let's flush this out, guys. So what are the other things that you do in these kind of cases now that you have a little bit of trouble in this?
I mean, primary, like we went over, try to go subintimal. I mean, you try to avoid keeping it at least subintimal as possible. But in your case, probably it was just extending down a little bit more than your comfort level. So if it doesn't really take the right track, then we just try to get tibial access and try to establish a flow, and then work antegradely if and when we pass through the lesion. So the primary goal is to, like Sachin was saying, to keep the primary patency and the limb salvage on in this case. So if worst case scenario, if the antegrade or the direct line of revascularization really doesn't work, then we probably do indirect revascularization. But hopefully we'll be able to get here and.
Well, let's see. We're going to try to do a DSA shot here. I mean, part of this is sort of trial and error, where you want to keep on injecting and or keep on trying. Liz, can you check her calf for me in a second? Not yet. When I tell you. There it is. It's on the side. That's the one, right?
Yep.
Okay, let's save this. Yep.
Yeah, the technical challenging part is you can feel the pulse. We are all used to feeling the pulse and going for it. Here it's all fluoroscopy guided. So.
Yep. So what I'm going to do now is put it on that other thing. The roadmap reset here. Hold on, Liz. Don't worry. Not yet.
So maybe if you go a little higher up, right there, yeah.
A little higher up may be the way to go.
Looks like a good spot.
No te muevas, señora. Give me some lighter. I think I'm going to need a longer needle than this. Yep, give me the other needle back. Okay, I kind of like that spot here.
I think you're very close. It's just.
I think I'm sliding right on top of it.
Yeah, you can see you're almost right on top of it.
Yep, I just slid on top of it. It's very calcific.
Yeah, that's the problem with these small lumen vessels, is calcification really
Do
deflects
another
and you
view
go
here.
off.
I'm going to go just to another view, just to make sure I'm okay. Right on top of it.
Yeah.
Very tough access, I got to tell you guys. Usually doesn't take this long. It looks like the vein.
Oh, yeah. That's.
I think we're going to flush it again. Flush this out. Sorry about the watching paint dry here.
I mean, it's a good learning case to how to get real tibial accesses because that is critical to your treating of CLI patients. If you don't have your plan B in action, then it's not a complete treatment strategy. So it's good to know and see how to get tibial access. And even if you take this lesson home, I think that's worth seeing a case. And the issue always becomes is we hit a lot of veins.
I got it.
Oh, there it is. Beautiful.
Okay, give me a off-road map here.
So I guess the learning process is to make sure, get 2 views or more to define your anatomy, use a micropuncture, make sure it's not the vein but the artery.
All right, well, it's definitely the artery, I can tell you that.
Yep.
So anyway, the point is, you can see the difficulties sometimes that we have. So, I'm not too, like I said, it is what it is, right? You deal with it, show me above, and you can see there's all the hibernating segment, right? And there's our other wire up top. So basically, I'm just taking it up to here. Now I'm going to put a dilator, micropuncture dilator, just a dilator in. So now that you have tibial access, you go ahead and put a small dilator, which is nothing other than a 4 French. And then what you're going to do is you're going to introduce your wire through here. So what I ask you guys to do now is give me 018 Trailblazer, okay?
So you plan to work over the dilator?
Well, you leave the dilator in and I let it bleed, right? Squeeze the calf for me, Lizzie. Make sure everything is okay up top. So what I do is I leave the dilator in, let it bleed, and I know people are like, I don't like it to bleed. I personally like it to bleed. We're going to give our Radial Cocktail, which Dr. Jane is going to tell you what it is. Can I get a fielder as well? A new fielder.
Can I get some nitro, guys?
Okay, so we're going to give a Radial Cocktail, which is, Dr. Jane, what is it? I know you're not mic'd.
Okay.
Can you mic Dr. Jane? So Dr. Jane will tell you what our radial, you can tell me and I'll
When
tell.
we do a radial catheterization, we usually give a combination of heparin, verapamil, and nitroglycerin.
So it's a combination of heparin, verapamil, nitroglycerin, and what's our concentration here at Sinai?
So we use 2,000 of heparin, 200 of nitroglycerin, and then 2.5 milligram of verapamil. Usually in radial we use 5,000 units of heparin, but here we already are therapeutic on Angiomax. So we 2,000 of
So do you guys hear that,
heparin.
guys?
Yeah, we can hear that.
Good, as long as you can hear it. Show me above. So you can see here, there it is, see? So I just need a support catheter, and I'm going to be able to snake my way through. So now I'm actually going to use a mailman. Give me a Grand Slam. So we're going to put a Grand Slam over which we're going to put what is it called? Confianza Pro wire,
200.
and then we're going to take it through. So remember, now you've created deception planes up top, so now you've got access below. I know this is a little cumbersome to show, and people are going to be like, oh, you should have had ultrasound, and I agree. I think ultrasound does help. But honestly, in our hands, we're usually much quicker than that. It was very difficult to get this access. So we got this access, and now what I'm going to do is I'm going to put a Grand Slam up just so I can get my 018 Trailblazer in. So I'm going to put the Grand Slam up into the vessel, and that's my Grand Slam, right? And the Grand Slam is there. Now I'm going to have Sachin and Sunil feed the 018 Trailblazer over this. Or you could use another, I use an 018 Trailblazer, but you can also use another fine cross if you'd like. You can use a quick cross if you'd like. You can use multiple things.
It's a combination.
So once we get the Trailblazer in, we'll give it. So what you can see is Sunil is not going to load it. It's right there. So guys, I want you to see that. I know it took us about 20 minutes to get that access, but God willing that with that access now, we're going to be able to do this case in the next 30 to 40 minutes. We generally allot about 2 hours for these CLI cases. Obviously being live with the lectures and everything and more discussion, it'll take a little bit longer than that. But you can see how Elizabeth has clearly sedated the patient very well, and Ricardo is on top of the equipment, so we're able to work very fast. I think a lot of it is planning. Ricardo had also prepped the leg as well as the groin for us. So this way we knew that if we had to get foot access, it was already ready to go. The only thing that we were remiss on is not doing the ultrasound, which I think would have helped us a great deal here. Pull the wire back a little, guys. Okay, now show me a little lower. Okay, so what I'm going to do is bring the trailblazer up, right, up to there. Take out this wire. Take out the wire. And then I'm going to have Sachin give the verapamil through the trailblazer.
So Dr. Christian, what's your experience with those pedal sheets now?
pull back.
Everybody's getting popular on and trying to work on it.
Well, the Cook pedal sheath is a very good sheath. We have used it. Generally, I try not to go through sheets, but sometimes you have to, especially when you can't give a balloon delivery from above. So sometimes we go ahead and do it from below. And doing it from below also helps us a lot in terms of pushability. So Cook also has these, they have the CXI catheter. They also have below-the-knee balloons as well. So the below-the-knee balloons are in a very stiff catheter. Ricardo, do you know the name of the balloons, the Cook balloons from below the knee? Up top over there, he's going to get you the names. So this way I can tell the audience. Yeah, restart the max.
Okay.
Okay, now give me the Confianza, guys.
Confianza.
Right.
And just going back in time and just talking about the antegrade access from top, do you use like a guide or a long sheath for support, or you just keep your guide at the SFA and just use a fine cross?
As far as, that's another interesting thing too. A lot of people go with a longer sheath, 55 millimeter sheath, whatever it may be. What I've generally done is just left it at the common femoral and worked that way. So there are multiple ways of doing it. I think it's all what you're comfortable with doing. And we've done a lot of these cases in this manner. So we're just going to continue that because it seems to work for us. See, this is the area that I was a little concerned with. Now I'm just going to, what I generally do is let the wire go up freely and then try to decide whether I'm happy with the plane of the wire. See, and the wire seems to be going up in a manner that maybe not be the best. So what I'm going to do is pull this catheter back again a little bit, and then I'm going to try and figure out how this wire is going to behave.
What wire is this?
This is the Confianza wire from below. See, this seems to be in a good plane the way the wire is moving.
Yes.
But then over here, that seems to be a little bit better.
It looks, you've probably crossed.
Unless I'm perfed out, which I may be. Remember, a lot of times you can perf into the vein. You can perf into other areas. See, I perfed into the vein here. You see that? So again, it's a wire perf, and that's why we work on Angiomax. Show me below, guys. Show me below. Show me above now. Show me above. Okay. Nope, I don't like that. So again, it's the feeling of where is that vessel going. And you might be saying, well, Prakash, why don't you advance your catheter? I don't want to because I'm not comfortable with the path of this wire yet. So what I may do is up to this point I am comfortable. So rail me, guys. Rail me, guys. Okay, rail me. See, I don't like this particular curve right here, but I still think that's okay in terms of the path of the vessel. Rail me. Okay. So what I'm going to do is advance my microcatheter from below. Okay, to about there. Now show it to me again. Now I'm going to start from above. And a lot of times you can work from above and below and are able to get what you need to get done. So I'm going to start from above here. Okay. So up to here we're okay, right?
Right.
So what I'm going to try to do is bring this catheter down to right about there, okay? And pull this wire back. And let's see whether I can advance this wire into this. I just don't like that. Now I'm clearly behind it.
Looks like you're subintimal from the bottom right behind it.
Moving there.
Might have to do the reverse card technique again here. Let's go to another view.
You just, I was going to say if you want to change your view to see how far you're.
We're definitely not that far away. So what I can do is just pull this further back to where I know we're true luminal and come from above. Can I have a wet one, guys? All right.
So it was almost intraluminal till 19, 18, yeah.
So this is really the needle in the haystack technique here. So a lot of times here, what you can also do is go ahead and balloon the plane and then decide where you are. Okay, let me just leave that where it is and come down with this wire. I'll take this wire out, guys.
That's the wire.
Uh-huh. Right there is the problem.
That's where your lesion is.
Yep. That's the plane right there. You see that we're getting right there?
Mm.
That's the calcium. That's the collateral. Right there. So let's leave that there. Come back from below. Now I think
That
we're
looks
okay.
better.
Now I think we're okay. Show me above. So you saw how I use one wire to guide, us into the thing. Now I'm gonna advance this one. Let me pull this one back. Hold on. No, hold on. Rail this, guys. Rail this for me. Rail, good rail. Show me down below, Sachin. Don't pull the wire. Don't pull the wire.
Don't pull that.
Now this is not advancing. So a lot of times when you're sheetless, it's harder to advance these catheters, as you can imagine. Just don't lose that wire, guys, for me. Just don't pull the wire back. Keep pulling it back for me. Keep pulling it back. Okay, that's good right there. Okay, now let's pull this wire. Okay, let's leave that there. Show me this. Now give me a fielder, guys. Now I know I should be in the regular segment here because I'm getting good blood flow.
Right.
So we're going to go ahead and cross from below. Don't pull this, please. Excellent. So now we have blood flow from below.
Fielder.
So now give me that Cook balloon. What balloon do we have now?
So now reaching this point, what are you thinking about your strategies? You're going to
Well,
go
my
work
strategy, what's up with my blood pressure, guys? She's sedated.
Are you going to work all retrograde, all antegrade?
A flutter, in and out. Yeah.
Oh, she's more into fib? Okay.
Yep. Looks intraluminal.
Intraluminal, or where are we? There we are.
Yeah.
Now we're intraluminal. So you see that, guys? So for the audience, that's how you make this happen. So now what we're going to do is we're going to try to go ahead and advance this rail, please. Nice rail. Even if the wire goes up now, I really don't care. I'm going to pull this wire out now. So now I'm going to pull this wire out from above. So now we cross from below, and now I'm going to put a 014 Grand Slam up to give me support, and I'm going to balloon the track from below.
Okay.
Then I'm going to wire from above, and I'm going to fix it. So it took us about 40 minutes to cross this lesion from above below. Give me another Grand Slam. So now what we're going to do is we're going to get the Cook balloon. Do we have what's the long balloon we have in the Cook? 3 by 10. 3 by 12.
120.
120? Yeah, give me the 120. So now the options are, at this stage, Dr. Vishal, is that we can easily go ahead and now balloon, snare this wire and do all that safari baloney, which I don't think is any necessary anymore.
Right.
Or what we can do is go ahead, if we can actually wire this other thing, it would be wonderful, which again, I think we could try to do. We could try to wire it. But what I'm going to do is just push this all the way up, right, in a nice C loop, so I'm not going to get in trouble. I'm going to ask Sachin to walk this out. Mm-hmm. And to avoid confusion, what I'm going to do is just pull my other wire catheter back. See, now there's no confusion. We only have one wire in the picture, and now Sachin knows when that wire comes back. So he's going to walk this back now. Okay? Now Sachin is aware that we have this. Now we're going to use the balloon from below. You got it, guys?
You got it?
Right.
Balloon?
Now we have brisk blood flow, which we expected, right? So I'm just going to put a little friendly pressure here, not too much. So I have done nothing but put a dilator, and I've done nothing but put a 018 catheter in this leg, in this foot. So right now, we're going to introduce this, and this is a 3.0. It's a 3.0 balloon through the foot, sheathless. So let's see how ambitious we are, huh? I mean, let's see. We've been pretty ambitious today, and so I think for the audience, I think what to see this. What is the name of this balloon again? I'm sorry. It's called the Advanced Micro Balloon. It's a nice micro balloon through Cook. Yeah. Comes in a short shaft. You can pull it, and you can just advance it through the skin and go ahead and do it. This is what we're going to do here.
Pull. It's an over-the-wire balloon, or
all these balloons are over the wire, as you know.
Okay.
And what we're going to do is, I mean, we can use coronary balloons if this doesn't go, but obviously I'm going to tend to use this as much as I can. And okay, the shaft has not been wet, so okay, it's going in barely. Thanks to Sunil's really good rail. so anyway, so now we're going in. So now I'm having really not much trouble pushing it. And I'm very happy up top because I've got a C-loop, right? So I'm going to go up to about here, right? Let's say right about there. Yep. Let's stop there, right? And then down here to about there, right? So now we're going to go up with the CXL balloon. Open an EXL, guys.
Go up there?
Yep. Slowly. Yeah. So remember, one of the things that we have to temper is our enthusiasm of balloon angioplasty. Do it nice and slow. There's no rush. Let things happen. I mean, you could say, Prakash, you might have oversized this balloon a little bit. I really don't think so, but we'll go slow. You can see how tight these lesions are.
Yep.
Right? So we're just going to, and you can see why it's so occlusive, so and why we had the difficulty.
Nominal is 8. We are at 3 now.
3. Okay, mama. No mueva. So there's one. One is giving way there.
That 16 was the tight lesion, and the 19 was the C2 where you're taking off. So
yeah, it's all very
right
tight.
there.
You can see how tight this lesion is at 19. So we're just going to go up very slowly. Let me just cine this for our records. Todo bien, mama. Okay, keep going slowly.
4 now.
What is she saying? I don't know. Moviendo. I don't know what that is. So
5.
5.
it's opening up. Yep.
6.
6.
There it is.
7.
7.
8.
8.
Okay, so now we're going to leave this up for a couple of minutes. And you can see here, it's just going to be a nice prolonged balloon. And I'm going to try to just get some antegrade flow through this. So now what I'm going to do is I'm going to ask Ricky. Ricky, give me a 2530 long balloon. 2530 long.
210.
210.
Evercross.
So that's one of the Ampheron Nanocross family balloons. So let me see again how this is expanding. It's expanding quite well. Obviously, it's not diluted, so my interventional fellow, Dr. Sunil, did not listen to me and dilute it. So down. So now I always want you guys to dilute the balloons as well. So now you're going to see this is going to be like watching paint dry, coming this down, almost as painful as me crossing this. So you can see here now, as Sachin is, we got it. You got to let it down. Yep.
So you have to take time for it to purge.
Yeah. You know how fellows are, Vishal. They're there to undermine you. That's all they are. He knew I was doing this live. He said, "How can I make Krishna look bad?" That's what Sunil said today. EXL. We don't have it. We don't have an EXL. Wow. Okay, walk it back. So what do we have? We're going to go up again. So walk it all the way to 30. Okay, a little more. Okay, go up again. So we're going to go up again over here. So we're going to dilute it this time.
So just for the audience, when you're trying to balloon and everything, what things do you keep in mind? Make sure you're not what's adequate. There's no incidence of perf or pain.
Well,
do you follow all these?
I think it's exactly what you and I have always talked about, right? One is the pain in the patient when we balloon. Obviously, there's a lot of lesions down here as well. You can see how diffuse this vessel is. There's also a bradycardia and perforation. you have to watch out for. So you can see here that she's having a little bit of pain because I can feel her moving underneath my fingers.
Right.
But that's okay. I mean, you know that you have good nursing with Elizabeth, and Elizabeth's going to go ahead and just feel it. I'm going to make sure she's not bleeding up top where we ballooned, which she's not. So we're just going to leave it up here for a little bit.
This is 6.
Just go to 8. 8. So in the meantime, what I'm going to do is I'm going to ask for a fielder, Elizabeth. And while this is here, I'm going to get a fielder through this one, through the one above, and try to wire it from above. So while we're allowing that to be ballooned, we're going to work and save a little bit of time and go ahead and wire from above, because the ideal thing is our final therapies are all going to be from above. So I made a nice liberal curve with my fielder. And you know what Elizabeth's doing right now is feeling the calf. I think it's a very important point, because I think what happens is on these patients, you can have these microperfs that collect. Excuse me, Liz, I'm going to flora. So these microperfs that are going to that may cause trouble. Whoops, the wire. Okay, the catheter's coming back. Okay, pull some positive on my catheter sheath. So you can see here that these microperfs can cause trouble.
Right.
So you know it's important to really have a good idea. That's a collateral. That's a collateral. Collateral. Show me a bit. Good. Okay. So you could wait. Don't push, please.
No push
Okay.
up.
Yeah. So you can see here that what I'm going to do is I'm going to try to side-by-side wire this, let the balloon down. So Sachin is going to let the balloon down now. And as the balloon is coming down, I'm going to try to wire from above as he walks it back without losing the wire. So what we're going to do is we're going to try to wire it from above and have access in 2 planes. Now you could balloon again and use the other balloon as sort of like a cutting balloon, but I don't think that's really necessary here. Okay, walk this balloon back, guys. So as Dr. Jane walks it back, I'm just going to go ahead and advance this forward.
Looks very nice.
Well, so far, you know, I've always been the skeptical type.
Especially when you know fellows are there to disrupt.
Especially the fellows, yeah, exactly. So now I'm going to go ahead and advance as he walks this balloon out. I'm going to advance this to here. You can walk it out now.
Balloon can come up.
Yep. Just don't lose the wire. And she's going to bleed from the leg. We know that. I'm not worried about that. Now I'm going to try to wire this into the AT.
Should be out.
There it is. See, now I'm in the AT?
Very nice. Yep.
See, now I'm in the arch, right? So then I'm going to take this down to the arch, take this out. Now I'm going to ask for another grand slam. Give me another grand slam, guys.
You can take this out.
Now I have nice blood flow in the arch. So now I'm going to take the grand slam and throw it in the arch and then take out this wire. So now we have access from above. Now we've actually done our duty, which is to revascularize this vessel. So now I'm going to ask them for a 2530 long balloon again.
210. You're on the 210, Ricky.
Now this is what Dr. Jane was telling you about. Now as far as the therapies here, you know, obviously DEB is not an option at this stage here. So the option is going to be really establishing straight line flow into the foot. So that's our goal here. So now I'm going to have them remove this wire as soon as I get access below. So now I've got nice access into the arch, right? That's fine. So anyway, I've got access below. Now Sachin, remove this wire, please. Just pull the wire out. And just hold a little direct pressure. Pulling it up. That's it. So now we're out. We have no access below. Here, walk this out, Sachin. I'll hold pressure here. Just light pressure. So now all it takes is two fingers to hold pressure here. And this will close off very quickly. All right, so now we're out here. And just a little finger pressure. And now I need the 2530, 210 tapered balloon. No, we got it. And
No,
give me the
the
atherectomy device,
nanocrust.
guys.
Nanocrust 253.
Yeah.
So are you a big fan of balloon tamponading that access site?
I don't think there's any need to. I mean, you could if you wanted to. I really don't think there's any need to.
So just manual pressure should actually work.
Actually, just a light manual pressure. You don't want to be occlusive. You just want to be light. So this way you're able to, go ahead and are able to allow for some perfusion. Our idea is to have a palpable pulse at the end of this, and hopefully we're going to do that. I'm not taking any pictures here because I did use about 24 cc's of dye to get access. So mag up, guys, on my distal. So what I'm not going to give any dye at all. More. Watch the wire, please. Let go of the wire, please. Good. Now hold it, please. Hold the wire, please. Thank you. Okay. So I'm going to balloon from here. So go ahead with the balloon. So we're going to go ahead. You can once the balloon goes up, you can let go.
Yeah.
So okay, come forward. Okay, ready, go up. So you can see it's a 2530. It's in a long tapered balloon. So which would just, now they over diluted, as you can see. But it's better to be over diluted than under diluted. So now we're just going to put a 5-minute pressure. Oh, lo siento, mama. Lo siento.
What's the nomina?
Poquito pressure, poquito? Okay.
10, okay.
Oh, can you talk to her, Ricardo? Okay, so that's at 10. So, okay, now let me go over some of the things that we're going to do. It's about 9:20. So if I can show straight line flow into the foot, I'm going to stop. I'm not going to stop. I'm going to stop transmitting, and I'm going to let you know what we're going to do because the rest of it you've seen multiple times. So one is what we're going to do is we're going to do a long segment atherectomy of this, and then we're going to do a prolonged balloon dilatation, and then we're done with the case. So here so the point of this whole conversation was to demonstrate different methods of crossing. And I think CLI has really become the next frontier for all of us who are doing this kind of business. I think that this lady, obviously with her atrial fibrillation or advanced age and other things, is really not a good surgical bypass candidate. So she would really be resignated to the alternative, which is really unacceptable in today's day and age. So what we can do here now is, since we've now established straight line flow into the foot, we can go ahead, send her for good wound care, and then she'll do much better. Dr. Jane is just checking her pulse. Any hematoma or anything?
No, nothing.
No hematoma. Wonderful. So I'm gonna after this balloon dilatation, we're gonna take one final shot, and we're gonna be done with it. We're gonna go ahead and do the work offline. I'll show you what we did in the future. So to summarize the points of what we did. So one is from up and above. When you come down, in order to do this, you need to visualize the following. You need to visualize the ostial cap of the occlusion of the anterior tibial artery. Second, you need to visualize any branches or any calcification. 3 is, in your mind, you need to be certain of the track of the anterior tibial artery. So you could see, what we did. We used any hydrophilic wire to get into the anterior tibial artery, injected through our support microcatheter, visualize the collaterals or the branches that come off. Then when we wired, we were very cognizant to make sure that we were not going into one of those branches. So we thought we perforated or penetrated the cap in the right spot, and then we were coming, but however, the track of the wire was not behaving well when Dr. Jane was presenting. So at that stage, you need to take a step back and say, hey, I'm not in the right spot. If you keep pushing, believe me, you're not going to get into the right spot because you already created a plane. So that's when you gotta stop, reevaluate. So at that stage, we said, let's get pedal access. You saw the struggles we went to, but I'm stubborn, I'm old school, so we do it under fluoroscopy. People can do it under ultrasound, which I think is much more efficient, and you go ahead and get it under ultrasound. But you can be done under fluoroscopy, as we demonstrated. Once you get into the pedal access, you go ahead and you wire going up. And when you wire going up, it's again important to understand the plane in which you're traveling. So if you're traveling in the plane that you know is going forward, then you saw how many attempts it took for us to really be certain. I never once advanced my microcatheter across the distal cap until I was certain my plane was, or my direction was something that was acceptable. So we did 2 different views to ensure that once we did that, we then used both wires to come down and create multiple dissection channels, allowing my confianza or my high tip load wire to penetrate past that dissection into the true lumen. Once we're done with that, we did balloon with the Cook balloon from below, And now what we're going to do, we work from above. We took the wire out, now we have access from above. So this is there's no sheath involved, there's nothing. Important thing to remember, when you get pedal access, even if you don't use a sheath, use your cocktail, or what we call is the radial cocktail here at Sinai, to be able to prevent spasm and extra things. Now, Dr. Jane is holding very light pressure, because heavy pressure will cause coagulation. You're always going to have an area of what looks like a spasm or narrowing at this level, but that's okay. That's what you expect. So now at this stage, we're done with this balloon. And I told you I was promised you of pictures, so down with the balloon. And now we're going to come back up and just do one more balloon up here at this level, just to really get all our lesions. Go up, please. So prolonged balloon with long balloons is really useful in these kind of cases. So, you know, don't hesitate to use long balloons, and don't hesitate to use prolonged balloons. These are not quick cases. So, you know, plan properly, plan your schedule properly, because it could take 2 hours. We started at, say, 8:15. It's now 9:25. We've crossed and we've ballooned. So generally speaking, this will take another 15 minutes for us once we come off air to get it done, because I won't be yapping as much. And that's it. I think that's it. Any other points here, Sachin or Vishal, in terms of any pointers that you guys can add to what we've done?
No, I think it's a very comprehensive and an excellent case to really demonstrate a success of a CLI, especially like you said, people like you are advancing to CLI program, to keep your options open, always have a plan B, pedal access, how to get it, and how to really intervene step by step. I think it was a perfect demonstration with all the ideal steps, and there's nothing more to add from my side unless...
I think the patience is the virtue here. I think it's being patient, you know, using you're really thinking about what's happening to that wire. I mean, we tend to push wires without really watching the tip and understanding, and I think that's the case. The only thing I regret here is that not having the ultrasound, because I think I would have used less dye. But I still think we were able to get in, and we used, 90 cc so far,
Yeah.
so we're not so bad in what we've done. Down, guys. I'm just walking this back, watching my distal wire, because remember, by definition, you're creating a lot of dissections. So we tend to watch our distal wire as we walk it back. And then I'm going to do one nice picture and walk this a little more. One picture, and then we'll come off air.
Resistance.
Yep, this balloon's not fully down. You're out? Okay, good. So let's put me on DSA, guys. Low mag now. Very good. Let's take a shot here. Ready?
Yep.
Inject.
Yeah, weight is filling.
Wow.
So,
Looks
not bad.
Amazing.
Not bad, right?
Beautiful.
I mean, I think we did a pretty good job. Now you're going to see, you might see the spasm here, which is okay. Inject again.
Wow.
So I was actually in a little twig of an AT. Notice how important it is not to advance the balloon into the DP. See that? There's another teaching point. You know, I kept wondering to myself, why is this thing behaving like that? And let me tell you, I look like a genius right now that I did not inject it, I didn't balloon into the tibia.
That's good.
So now I'm going to go ahead and just replace my wire where it should be, which is very important, right? You know, Elizabeth doesn't agree I'm a genius though, but that's okay. Right, Liz? You don't agree that I'm a genius?
Liz probably needs her coffee for the day.
Yep, exactly. Duele mucho? No duele, okay. All right, good. So we're done. So we're going to do our atherectomy now. You saw how we have established wonderful flow into the foot, and Sachin's going to finish up doing the atherectomy, and I think it's a very good demonstration of what we wanted to accomplish. I thank you, Vishal, for always being here, and Sachin, and our wonderful team, Elizabeth, as well as Ricardo, and our wonderful media crew here. Thank you again, and we'll see you next month.
Thank Thank you very much, Dr. Krishnan, for an excellent case and a good success results at the end. Thank you, everyone, for tuning in live. Our next case is scheduled for September 23rd, so we'll see you there, 8 o'clock in the morning, Eastern Standard Time from Mount Sinai. Thank you for me. Have a great day.